And then we live?
Yes, Andrew, we're live.
Good, okay, excellent. So welcome everybody to this part one governing body meeting of the South West London CCG. The meeting's being broadcast live and it's being recorded, so it'll be uploaded onto the CCG website. Members of the public can observe the meeting and they can ask any questions they want to live, and we'll do our best to answer those questions in our agenda item number 11 at the end of the meeting if we have time to do that. We haven't had any written questions submitted in advance, so hopefully we'll be in a position to take any questions that we receive live. I've got apologies from Dr. Patrick Gibson, who's the GP Borough Lead for Richmond, and I've also now got apologies from Dr. Agnello Fernandez, who's the GP Borough Lead for Croydon. Before we go into the main part of the meeting as well, I just wanted to acknowledge that this meeting is the last meeting for Les Ross, who is our secondary care member of the governing body. His term comes to an end at the end of March. I just wanted to say a public thank you to Les for all your hard work and support this last year. We really appreciate your input. It's been a difficult year to be fulfilling that role, and I really appreciate your support during this year. So thank you, Les.
Thank you, Andrew.
We've got a declaration of interest register which is available to everyone in their papers, so that should be available to members of the public as well. And there's a glossary, an acronym buster on the CCG website for members of the public, but we will do our best to not talk in acronyms and jargon, so I hope that what we say will be generally intelligible. We are quorate, so I will proceed with the meeting. So can I ask first, in terms of declarations of interest, can everyone confirm that their current entry on the register of interest is accurate? And are there any particular interests I need to be aware of for any of the items on the agenda? No? Okay. In that case, I shall proceed, and I'll go straight into item 3, which is to approve the minutes of the last meeting, which was on the 4th of November. So can I just ask whether there are any issues of accuracy in those minutes? No. So are we happy as a board to approve the minutes of the last meeting? Yes. And I haven't been notified of any matters arising from those minutes that we need to pick up. So I will proceed. So let's go straight on to the Chair and Accountable Officer report. It's actually all for Sarah, this one. So Sarah, I think all the substantial items are in your section of the update. So I will hand over to you.
Sorry, I think I lost the end of that, Andrew, so it might be my connection, so hopefully people can hear me. So there's not very much that isn't already on the agenda today. So firstly, just so people are aware, since the last governing body meeting in public, that the ICS white paper has been published, and we are expecting legislation to go through in the next few months. So we await more information on that, but that is available for people to read. And then just finally, which I think, we couldn't leave without recognising the significant pressure that the system has been under in the NHS over the past second wave of COVID, but also recognising that it's currently getting better in the respect of the numbers coming down, but there's still pressure in the system due to the fact that we are seeing people who are non-COVID patients within our hospitals and within primary care and community as well. So we want to support our staff because we want to make sure that they get a break, because we are still planning for both restart and recovery, but also any further waves of COVID that may come in the future. So just to let people know, that's where we are, but we are planning together as a system, and I think in South West London we're doing a good job of working collaboratively and trying to support our staff across South West London. So that was all I was going to say on that, and there's further information we can give to people on those things.
Thank you, Sarah. So any questions for Sarah on that? Pippa.
Sarah, thank you. Really helpful report, and I think the whole governing body would thank everyone in the South West London system for their incredible hard work to date and ongoing. And it really has been a really good response and a lot of hard work. I was really pleased to see in your report the point in section 8 where you talk about the out of hospital support that's been put in place for everyone in South West London. And I note in the papers later on there's a comment about the hospital discharge funding, and I wondered what your thoughts were about how much of that is going to be able to continue going forward, because it seems to be critical part of our recovery programme.
Yeah, I wonder if Andrew, I can bring Lucy in to talk about the plan that we have to review the current arrangements and to see what we need to take forward.
Yeah, very happy.
Yeah, thank you, Lucy.
Very happy to, Sarah. Thank you, and Chair. So Pippa, yes, you're absolutely right. Having a coordinated and enhanced discharge process has been key to managing COVID, and we have a regular meeting of the exec discharge leads across South West London and have put a range of additional services in place, which, as you rightly say, have had some additional funding. We are expecting a proportion of that funding to go through into Q1 of next year, but we're also doing an evaluation of each of the initiatives that we've put in through this COVID Wave 2, South West London Bed Bureau, virtual wards, additional capacity in key areas such as neuro rehab, therapy rehab, and of course the COVID positive nursing home, the temporary alternative discharge destinations, so that we can consider which of these are the priorities to carry forward into the next wave, and particularly, if not the next wave, into the future as we start to gear up our elective programme and ensure that hospital flow is maintained in the way that it has been to date. So we're looking at all of that very carefully. We're not we don't have all of the information about the funding flows for next year, but we're confident that the key priority work streams will be continued into Q1 for next year.
Thank you, it's really helpful.
Thanks, Pippa. Does that answer your question?
Yeah, that's very helpful. Thank you. Thanks.
Thanks, Pippa. Sorry, I think my connection might be coming in and out a bit, so apologies for that. Bruno.
Yeah, good morning, Sarah. Vis-a-vis the white paper and the expectations that it has of the health and care partnerships and the fact that work needed to slow down over or during the epidemic on the development of the ICS at Place, have you given thought to the best way of restarting that work so that it will meet the expectations of the white paper by April next year?
Thank you, Bruno. Yes, well, we have got work going on a transition programme for South West London. Obviously, we still need to wait the legislation and further information from the national team, but we are looking to how can we start to restart working. Well, we're already still working at Place. Let's be fair about it. We haven't stopped working at Place. It's just about how do we start to move from where we are now into the sort of future flying formation. So we're starting to think about that as a system, and we are starting to put in place a transition programme which includes transition leads at Place level from all of the different parts of the system. But we still need to await, I think, further guidance before we formalise everything into an April 2022 kind of way of working. But I can assure you that the whole of the system is engaged in work to think about transition and to think about how we might take this work forward.
Thank you for that, Sarah.
Thank you, Sarah. So with no more questions, I shall move us straight on to the next item, which again is for information, which is an update on COVID vaccination. And Matthew, you're going to be doing that for us.
I am. Thank you very much, Andrew. I know there's lots of people who are involved in this work, so the paper is provided. I don't propose to present to that, Andrew, but I would say a few sort of covering remarks, and then happy, of course, as always, to take questions. I mean, I think first and most important thing to say is a big thank you to the staff across South West London who have been involved in rolling out the vaccine programme. It has been an amazing effort, and South West London has done its part to what I think has been both regionally and nationally a fantastic situation thus far, and long may that continue. And I think it's absolutely right and proper that as the governing body that we formally note our thanks to everybody involved in this process, not least because primary care has thus far taken a significant strain on this. It's done about 70% of all the vaccinating across South West London thus far, and therefore primary care has been very much in the forefront of this endeavour. And again, important to note that that is on top of everything else that primary care does on a day in, day out basis. So that's the first thing. Second thing to say is it's not just a thank you for the work, it's also well done because we've achieved the early milestones of this rollout. So the first 4 cohorts was achieved by the middle of February. That's both in terms of the offer to all and indeed the expected take-up in overall numbers. South West London achieved both of those important first milestones. And furthermore, if you look at the detail around what's not very pleasantly called cohort penetration, but the take-up of the vaccine per individual group, South West London is, as a collective position, in a strong place with regard to how that has played out, and that's both in absolute terms and in relative terms compared to others across London, and so I think that's also credit worthy in terms of the work that's been done thus far. Obviously, we're now moving on to the next set of milestones, which is the end of April for the next 2 cohorts, and to that end, primary care remains very engaged in that process, but we're also bringing the additional capacity through the large vaccination centres, which are rolling out by the end of this month. We expect that those large vaccination centres across the South West London patch will all be up and running, and they have a part to play now, but will also have an increasing part to play as we roll out to further cohorts. And you'll note, of course, with interest that the JCI, who are the body setting the timetable of the rollout, has continued to do so in age categories, with the next group being the 40 to 9s, and following that the 30 to 39s, etc. So the large vaccination centres will be very much taking a sort of a lion's share of that work going forward, as hospital hubs and primary care focus not solely but significantly on second doses, with first doses being more in the large centres, and of course the increasing number of community pharmacy sites that we have up and running as well. So that's a bit the sort of broad picture, I suppose. In terms of the challenges, this is not a straightforward piece of work, and it's complex with issues such as the supply of the vaccine, the workforce, to ensure that we've got the workforce in the right place to do this, and indeed that in places such as the large centres, we're creating new little organisations, and we need to take care to look after the staff and create systems that are robust and well organised and running efficiently and effectively. Those are the sorts of challenges that we're facing. We're dealing with those. We have a board for South West London that Tonya and I co-chair, and a whole range of people putting in a very, very significant amount of work to keep those challenges and risks in hand. And I would reassure the board at this moment that we do have those in hand, but of course we are merely at the start of this process. We've gone through a couple of big milestones, but there is much more for us to do as we roll this out to the rest of our population across South West London. And so that's probably all I need to add at the moment. Say one final point, which is the biggest challenge probably for us, and I would suggest across the country, is to make sure that now we have the mechanisms in place to deliver the vaccine. Vaccine supply has been, up and down at times, but we've maintained being able to give vaccines. The challenge now is to ensure that people who can get the vaccine come forward and get it, and there is a variety of take-up rates depending upon a whole range of factors, ethnicity being one, deprivation levels being another, and that area where we don't want to create an inequity between our populations is where there is significant work, and communicating and engaging with the populations at large will become increasingly the mainstay of this work now that we've got the delivery channels largely in place and working. It's about making sure vaccine take-up is high, and we do all we can with our community groups and community leaders and ourselves as statutory agencies to encourage our population to take the vaccine, because that's clearly, from a population health perspective, crucial to be our way out of this pandemic, along with, of course, washing our hands, wearing face masks and socially distances. I am contractually obliged to say that every 5 minutes, so I've just got it in time, and I'll now take any questions, Andrew, if that's sufficient of an update.
Thank you, Matthew, really helpful. And Tonya, did you want to say anything as well? Because I know that you've been leading the programme alongside Matthew.
No, I think Matthew covered everything, and just again to extend my thanks as well, and just that we need to push on now, don't we? Because we've done very well in the first. We're actually 5 and 6 cohorts now, but we know the general population piece is coming upon us, and that is a different ask to what we've done before. So yeah, just onwards and upwards.
So before I open it up, I guess I do just want to say thank you to both of you for your leadership of this, and we need to just acknowledge the incredible work of everyone involved in the vaccination programme, particularly in South West London. I do think we've done phenomenally well, and I know how hard people have worked at every level to deliver this, whether that's in the hospital setting, the max vaccination centres, or our primary care networks, where I think it's been absolutely incredible how our PCNs have stepped up to the challenge and really taken that on. And I think it's been good for their development. It's also kind of reaffirmed the value of that PCN approach to delivering services in primary care, and I think that's been really good to see. Let me open it up to Susan first.
Thank you. I just also like to say I've been privileged to hear about the development and the rollout of the vaccine at a number of meetings, and I'm in awe of the work that's been going on. I'm also conscious of the massive amount of communication activity that's going on to reach out. One of the things we're obviously trying to do is to overcome the barriers that people have to wanting the vaccine, and where those people are registered with the general practice, at least we know who they might be. There are communities in South West London, the homeless, asylum seekers, perhaps, who aren't necessarily as well connected. It'd be useful just to hear about how we might reach out to those who perhaps aren't on our list. Thank you.
Thanks, Susan. So let me take questions from Pippa and Dagmar as well, and then I'll come back to you, Matthew and Tonya, to respond to those. So Pippa?
Thank you. So Matthew's answered one of my questions. The other question was you've given us a really good update on percentage of populations and the cohorts and where we've achieved, and some great achievement. But the health and social care workers, I'd just be interested to know where and how we're progressing with that across South West London.
Thanks, Pippa. Good question. Dagmar, can I come to you?
Yeah, so hi, and apologies for being a bit late. So I'm adding my thanks. I know you've heard it, but it is amazing, and it was just a fantastic, somehow nice thing about this pandemic. I have to say that was the highlight of the pandemic. So from our point of view, obviously, as we laid out, the challenge is to not leave anybody behind. I think that's what the programme is now called for the NHS as well. And that requires hand in glove working with us in local authority, and that happens very much on the ground. So I'm very keen to really have almost like a systematic mop-up programme, because I know that you're still very much looking forward. We need to get through all the JCBI cohorts, but that's the one thing. The second one is the second dose, and the third one really is the mop-up, and that we look at that in really these three strands, because some of the issues that we find as well is obviously, as Susan, you said, a fantastic, again, integrated comms and engagement program in what we sometimes call hesitancy, is actually access. Yeah, or it's a bit of both. So people are not 100% sure. And if it's then a vaccination centre far away that they don't know, that just tips them over the edge. Whereas if it's in the well-known and familiar face setting, community setting, it reduces the barriers. And there are already really good examples of the pop-ups. I mean, Fiona, for example, in my patch, she's rolled up her sleeves, and I mean, Morden Mosque had over 1,000 vaccinations. So brilliant. For me, that needs to have a little bit more of a structured approach and an evidence-based approach, so that we also then see, has that mopped up who we need to mop up, so that we keep the door open. And if I think longer term, obviously the variants are all around us and we're trying to chase them, as you well know, but there might well be the requirement for revaccination, etc. So it is for us as a board, I think, quite useful to think a little bit longer term as well, and how we set ourselves up. So starting now to think there might probably be some opportunistic vaccination program that we need to start to think how that happens, because if somebody pops in and has whatever, their inhaler redone, and you see they haven't had their vaccination, if you have it there and then, we know that from fluid works quite well. So I wanted that for us to start to think about that now. Thank you.
Thanks, Dagmar. Really helpful as ever. So let me come back to you, Matthew and Tonya. Do you want to just handle those questions between you?
Yeah, happy to. So in terms of both the point that Pippa made around, Susan made about hard to reach groups, and Dagmar, you reiterated that. We have a work stream for all aspects of the programme, one of which is to try to identify those groups who perhaps might choose to or have no choice but are under the radar, and that's a important part of the work stream. Obviously, we have the homeless, we also have asylum seekers, we have sex workers, we have the Gypsy Romany community. There's a whole range of people who are differing numbers across South West London, but it's a South West London wide initiative, and will be a South West London wide response. We have somebody who is pulling together options for how we can address each of those groups. We have the vaccine board on Friday this week, where we're expecting to see an update on that, to sort of do, I think, Dagmar, what you are suggesting, which is to have a bit more of a structured approach to this, to make sure that we don't say, well, hard to reach or underserved communities, and therefore they're in the too difficult box. Well, it's even more important for that group of the population that we don't see it as such, and that's why we have specific work, and we'll identify different things to do that helps to cover that. Now, clearly the second dose piece, Dagmar, that you reference will be more challenging with some of those communities, I don't doubt. So that's going to be the second issue, but that's the first thing is to make sure we can identify, work through solutions, and then implement those on a sort of area by area basis, and that's what we'll be doing. I'll perhaps take the health and care workers bit, Tonya, and then it might leave you to do the longer term piece, and add anything that I've missed on what I've said so far. In terms of health and care workers, Pippa, it is a really good question. We have offered it to all health and care staff, so we're confident of that. In terms of take-up rates, directly employed health and care workers to South West London NHS and care organisations, it's a slightly tricky number to be absolutely categoric over, because there are allied health professionals such as physios from the private sector that are included in their sort of overall numbers, which obviously are in a slightly different category. But we know that at least 70% of directly employed health and care workers have been vaccinated as a totality. That does slightly cover the fact that there are some ups and downs in that, particularly based on ethnicity. So within my own organisation, there is a difference between white health and care health staff and staff from a BAME background. That difference can be towards 20% less for the BME staff at this moment, and that's obviously a big challenge for us. In terms of social care workers, we believe that we've got close to 90% of that workforce now vaccinated, and for care home staff it's at 74%. So we're getting, I think, good coverage, but clearly we want it to be better than that, and that work continues at pace in all organisations. And for my own, for example, we're now we have AstraZeneca as coming on stream. We're going to be doing roving vaccination, obviously with Pfizer. That's much more difficult to do because of the way you have to manage the vaccine. So now we have some AstraZeneca. We're going out to wards and departments, taking vaccine to people as a way of trying to get that last group of people through who may have not got round to it, be a bit hesitant. There will, of course, always be some people who just are implacably opposed to this. We're not in a mandatory situation as yet, although I did note with interest the news this morning that there is some talk of mandation for health and care workers. I don't know if that's going to come to pass, but that's not where we are at the moment, and as a consequence we are doing everything to encourage. We are not mandating it at this point. So that's hopefully helpful responses to those three areas, but I'm sure Tonya will add things that I've forgotten and perhaps might want to talk about the longer term piece as well.
Yeah, I mean, sorry, Andrew, can I just briefly around the no one left behind, because I think that is really important, Dagmar, and I think if you look at our percentage uptakes, we are still seeing improvement in those first 4 cohorts. That means that we are, we're not doing that, we've done this, we're moving on now. So we are still very much concentrating, because our target is 100%, and that's what we aim to get. So I think that, but we know now that we need to do some more in-depth work with some of our communities, and we are now starting to get that ward level data, which we think we will be able to share. Well, I know we'll be able to share very, very soon with boroughs, which I think is really important when we have those discussions. And I agree we need some systematic, but I do think it's borough discussions as well, because that data will be different across boroughs. And I think that ownership at a borough level about what works for the communities that we want to see, we want to support to come forward for the vaccine is really important. So, and I think the mop up, because you're absolutely right, there's some learning here, not just for the COVID-19 vaccination, but also for our other immunisation programme. So one that springs to mind for me is flu. Just to say, community pharmacists, the second wave of EIOs, or expressions of interest for community pharmacists, has closed. We now have a longer list of community pharmacy sites that have, say, expressed an interest to become a vaccination centre for South West London. So we're just going to work through that list and again come back to boroughs, because whilst we want to encourage as many community pharmacists to come forward, we also need to be a little bit tactical about where they are. We want them in the places where the uptake is the least. We want them in our more deprived wards, don't we? So again, working with boroughs to say these are the people that have come forward. Where are the best ones? That, should we have them all, or should there be some that we prioritise over others? So yeah, I think we're coming next week, and myself and Charlotte coming to talk to TPHs next week, so we'll pick some of this up then. Dagmar.
Thanks, Tonya. Really helpful. Right. So that was
Andrew. Can I just add one quick additional point, and then just a further thank you that I forgot to add at the start. So the additional point is on this longer term piece. I do think one of the conversations that we'll be having within the vaccination board, because it's the right thing to do, but I suspect we're also going to be asked to do it, is to think about what does the structure of ongoing vaccination look like. If we're talking about an annual COVID jab as well as an annual flu jab, how does that play out? What infrastructure do we need to be able to provide that on an efficient and effective basis that also doesn't bake in access concerns? So you have a few places that are easy for large parts of the population, but not all of them. That clearly isn't going to work. Now, I think some of the final discussions and agreements on that will need to also reference the state of the vaccine itself. So if it becomes a bit more like the flu vaccine, which is pretty portable and relatively, and I use my words carefully, straightforward to manage and administer, that's going to change things. If it stays a bit like we have now, then that obviously does limit our flexibility. So I think it's a good question to raise, Dagmar, and it's definitely one that's in my mind. And as soon as we have a bit more clarity, we'll be able to, I think, make some decisions about that for the longer term. And I should have said when I was saying the thank you at the start, also a big thank you to the huge number of volunteers who have been part of this. This is not just about NHS staff stepping forward. We have all sorts of people volunteering and helping, and that I think also reflects really positively on the overall endeavour on this. So that should be noted as well.
Thank you, Matthew. Really helpful to remember that. So that was for noting and for information. So thank you very much. Really helpful update and some really good questions. Let's move on to item 6 on the agenda, which is where we go through updates and reports from the various committees. And the first one to go to is Audit Committee. And Paul, who is our Audit Committee Chair, is just going to give us an update on what's been going on in that setting.
Yeah, thank you, Chair. So just to give the governing body an update from the Audit Committee, that the last one took place in January of this year. I'll just mention 4 or 5 items that I think are worthy of interest. So on the first one, on the primary care rebates, this was to align the 6 different CCG schemes that have been operating their own rebate policies since we came together. And this was all about bringing together a joint policy. The policy had been approved in principle at a previous committee. This was just some slight changes to the wordings and slight amendments that had been made. So that was agreed. So that policy is now being signed off. The next item was the update with the external audit and the approach to the 2021 accounts. We did speak to our external auditors, Grant Thornton. They weren't able to give precise details back in January, and there is an audit committee next week, which they'll give us a full update. But I think our key concern is that the normal business rules, we've applied in previous years around revenue and capital and cash flow. Obviously, the whole situation has changed this year. The financial and operating plan has changed, and we just, looking to understand the rules, making sure that we would be measured in an appropriate way. So we'll be updated on that next week. I think the other thing just to mention there, again, just some new standards that were brought in, and particularly one around the process or the risk assessment process for estimating key account entries. So the audit committee and those charged with governance were asked to look at this, and particularly with regards to key estimates such as depreciation, year-end accruals, and provisions. We need to understand the process and the thinking process that goes behind that. So that was discussed and will be confirmed next week. The next item I would bring to attention was the internal audit progress report. I think that the only item there that's probably worthy of mention is we had a partial assurance report on the procurement and contract management. And although the audit identified strong compliance and governance in contract management, I think one thing that came out of the testing that they did was some of our contract registers, or some instances, they need more timely updating, and we also did find some contracts that were unsigned. So that will be followed up, and we'll note on progress at the next audit committee. Then I think the other thing, just to mention briefly, single tender waivers. As people will be aware, there's obviously a high volume this year. They principally come through Finance Committee. There's also assurance, myself and Chair of Finance review these on a regular basis as well to look at expenditure. So, in terms of ensuring that there's robust governance around this, particularly with COVID expenditure and having to issue fairly quickly single tender waivers, we are reviewing those on a regular basis, and they do come to Audit Committee just for notification. Very quickly, final two I would mention, the risk management framework. This is something that's been developed by Ben and his team. We obviously go through Audit Committee to provide some more input, agree on key principles and the governance around that. And I think, Ben, it's consultations being done and final approval is now being sought on the risk management framework. So that process is now complete. And then finally, the last item on the agenda around the systems update in the ICS, that's more really just to understand the developments there, making sure we can start to identify the impact on the systems and the governance for the CCG over the next 12 to 13 months. So I think, Chair, those are probably the key items I would bring to the governing body's attention. And as I mentioned, there is another audit committee next week, and obviously I will update the governing body on key items from that too.
Thanks, Paul. That was really helpful. Are there any questions for Paul in relation to what the audit committee have been doing? No? Okay, thanks. That was really useful.
Thank you.
Should go on to Finance Committee. So David, if you give us an update on Finance Committee, and then we can probably go straight into the finance report and then take questions in the roundabout finance.
Yeah, thank you, Andrew. So the report summarises the meeting we had on the 26th of January. We also had our February meeting on the 23rd. And in addition, we're having a number of extraordinary Finance Committee meetings because of this point that Paul has just raised around the number of single tender waivers that we're going through, and the ones that were approved at the meeting on the 4th of February are noted in the report. Really, just to pick out a couple of things. So continuing to scrutinise the finances of both the CCG and the system. And on the 26th of January, we looked at month 9. We'll talk about the more up-to-date position in the next item. And then we've been just noting a number of exceptional expenditure request for COVID. Again, they are, to assure the board, they're also going through a process where myself and the chair of audit meet fortnightly with the chief finance officer and the accountable officer to go through all of those as well. Just on, if I can make a point on the single tender waivers, there's a long list there. A lot of these are legacy items that go back to the previous CCGs that we're working through, and we've got a number of processes in place around those ones, and also new ones that are coming forward that the Finance Committee is looking at. Happy to take any questions. Thank you.
Thanks, David. That's really helpful. Why don't we go straight into James's finance report, and then any questions either for David or James we can take together.
Okay, thank you, Andrew. So I'll try and keep it brief. So we've submitted the month 10 report, which you've got in front of you. As is highlighted in the previous two discussions, it's been a very different year, and if people recall, we submitted a plan for H2, as we now like to call it, in the NHS. CCG is on plan to hit its control total for that. Pretty confident that we'll get there. We're receiving external funds for the discharge plan, which are coming through fine so far. We've had month 9, and I think I understand we just had month 10, and they're trying to do a wrap up ahead of the year end for month 11 and 12. The costs for all the vaccine programs go separately, so Croydon act as a host for that, the hospital, and again the money for that is flowing through, so that doesn't represent a particular risk. As a system as a whole, again, we spent quite a lot of time setting up the plan for H2. On expenditure wise, I think we're pretty much where we would expect to be. The one issue we're trying to resolve at the moment with London and National is, if people recall, the whole issue about non-NHS income, which is incredibly technical and horrible, and we're trying to work that through at the moment, and working closely with London and the providers to sort that. If we can sort that as well to our satisfaction, I think we'll be clear to hopefully hit the system control total at the year end as well, which will be an excellent achievement to get there. In terms of the year end, we're now gearing up for that, as Paul and David highlighted. It is going to be a very different year. So there is going to have to be some national sort of discussions around that, and we're working those through Finance Committee and, as Paul said, Audit Committee and our external auditors to make sure that goes through as easily as it can do, given the challenges that everybody's had this year and the changes to the system. In terms of next year, we've got a little bit more clarity around next year in terms of we won't be moving straight back to the old ways of working. So for Q1, we've had that confirmed that will be another sort of rollover of what we've been working to for the second half of the year. There will be some tweaks, so the discharge scheme won't be in place in the way that it has, and things like IS will be purchased locally and those sorts of things. So we'll work through what that means in terms of the technical side of for the CCG and the rest of the system. And the other thing is we won't know until later in March what exactly our system envelopes are, and also what the trust block contracts are, which are being recalculated. So we're going to be working as we have done for the last 12 months in fairly uncertain times for the next few weeks. But we'll bring that back again through various committees and back to the Finance Committee. We don't know at the moment. There is some talk about that might be extended to Q2 possibly, but we don't know that yet, and we're not likely to find that out just yet. We do know that after that period, we will be going back to a more normal way of working and a more normal way of allocating resources. and therefore we'll have to work through a sort of planning round in sort of April and beyond to make sure we can get through the rest of the year, and that will put a different focus on finances. To gear up for all of this, we've now, as people are aware, because I think we've taken it through various forums, set up a planning and prioritisation group to help us steer us through Q1, which will get us to help the system as a whole and the CCG as part of that system to manage both the finance and the priorities and how the things we're going to deliver. So we've got the first meeting of that later today, actually, and again we'll report back from that into various organisations, committees, through the statutory governance arrangements. So I think we're geared up to get ready for what's going to be another uncertain period on the finances, and I'm confident that as a system we'll manage that with the best way that we can as we go forward. So happy to take any questions or queries around any of that.
Thanks, James. That's really helpful. So shall I open it up to any questions or comments on either what David has presented or James's finance report? Sorry, I've got drumming going on in the background, if you can hear that. So I'm taking it people are happy with that. I know you've been kind of kept abreast of that as we've gone through, so it's not new to you. Okay, good. I'll take that as noted then. Let's go straight on to the Primary Care Commissioning Committee. So Susan, you're the chair of that committee. Shall I come to you?
Okay, thank you very much, Andrew. Yes, so the report just highlights a number of meetings that we've had. We've only had one public Primary Care Commissioning Committee, that was in November, and then a couple of part twos in order to make some decisions. The part one I always find and the public meeting were really helpful when we get an oversight of the strategic piece of work that's going on to support primary care, and then some insights from the boroughs. We also had some feedback, as you see, from the National GP Survey, and some actions that we need to deal with to support practices to reduce variations in terms of the experience that patients are having. The one thing that I was going to just highlight to the governing body was that we have been reviewing a change of control around a contract for AT medics. You'll see that in the notes. This is being managed on a London-wide basis, and they received a change of control request, and we wanted to make sure that all the CCGs are responding consistently. Legal advice has been sought, and we were made aware of a range of due diligence activities. We were requested under Chair's action, Part 2, to consider this due diligence, which we did on 2 occasions, and we're going to review that decision and discuss it at our next public meeting, which will be on the 31st of March. Apart from that, that's what I've got to say, so I'm happy for questions to be raised.
Thank you, Susan. Liz from Healthwatch, did you want to come in?
Yes, thanks for that, and thanks Susan for that helpful new piece of information, and we look forward to hearing what will be said on the 31st of March. In fact, it was that phrase AT medics that the South West London Healthwatch discussed yesterday, and I did alert Susan at our pre-meeting. Unfortunately, the order was not quite in the order we'd have liked, but still, that we would be likely to be raising it because we picked up, in fact, from an item we read in The Guardian on the 27th of February, that AT medics probably referred to the agreement for the contract for 3 Croydon practices to be taken over by Opero Centene, which is a US insurance firm, and now runs, we think, 49 practices in London and the South East. When we discussed it yesterday, some of the South West London Healthwatches had concerns about the apparent lack of transparency in relation to this decision. All of the 6 health watches ask for assurance that due process and due diligence were followed and that the transfer will not affect the quality of services nor the experience of people using them. So we would be grateful to have those assurances. And Susan, if you could just run past us again what the plan is then. I think, did you say that the decision would be reviewed?
No, I said we would talk about the decision that we made, so it's in the public domain, and the rationale behind our decision at the 31st. Right. But Mark is probably better placed to respond to your other query around the...
Yeah, so thank you.
So Liz, I think they're pertinent questions, and I think particularly the focus on the experience that we think patients will receive as a result of the change is the most important thing for us to be concerned about. Mark, shall I come to you?
Yeah, so thanks for those questions, Liz. I think just in terms of Susan's update, so absolutely right, the change of control was requested in November. We're doing a London kind of consistent approach to this. Legal advice was sought and independent due diligence carried out, and in that due diligence there were the impact on the patient, performance, finance, etc. And so a full range of due diligence went through, and we assured our PCC that had been done in the part 2. The due diligence and the legal advice actually brought us to the collective conclusion that there was no reason to refuse the change, and we are following the process of taking it to part 2 because of wave 2. A lot of our governance was stood down formally, but we will be taking the decision and taking it through part 1 on the 31st, as Susan says. The really key thing I think is also to mention that AT Medics still hold the contract. It will be the same people delivering the same services. It's not a change to the APMS contract. They will continue to be performance managed the way that they currently are and the way that all GP practices are, and they will still be seen by rated by CQC. So in terms of performance and impact on patients, there is no reason for us to not agree the consent.
Thank you.
Thanks, Mark. That's really helpful. Pippa, can I bring you in?
Thank you. So this might be a question for you, Mark. The GP Access Survey, really good to see the responses and the outputs for that. This was something that in the previous CCGs, when I used to sit on the Primary Care Committee, I know they were looking at, but I wondered whether we are still looking at reducing the variation between those practices with the best scores and those with the least scores. In other words, are we trying to reduce that gap? And then I think if we are, I think it would be good if we could get that reported in a year's time. So I noticed that there's some work going on with practices, and you've highlighted what those areas are. But it's about trying to reduce that variation. So we've got some practices who are really, really good at this, and some that do need more support. So how do can we reduce the percentage between the two, borough by borough?
So Susan, do you want me to take that? Yeah, so I think you're absolutely right. I think in terms of the survey, we take the survey findings, we share them with our boroughs, as well as looking at them at the primary care transformation and cell. And so there are a number of things that we're doing. We're doing action which is across the board, which is a systemic action, but also at local. We are monitoring those and working with specific practices to improve where they stand basically in the benchmarking and to improve, but also to learn from other practices that perhaps have sorted it out already. Yeah. So the very simple answer is yes, we are looking at that, and we will have an improvement plan across the board.
And can we report it in that way to see whether that gap is closing?
Yeah, I'm sure we can actually take that offline and discuss with you the kind of the regularity of that.
And I'm assuming we're wanting to close the gap by improving the performance of those who are performing worse rather than just closing.
That would be good, Chair, I feel.
Yes, absolutely, I think.
And let me bring Nicola in.
Yeah, thank you. So
the GP leader for primary care Pan South West London. So I value your thoughts on this.
Thank you. Yeah, just to build on what Mark's saying. So I think the first thing to say about the survey is we performed extremely well in South West London on the survey generally. And of course, what we want to do is level up. Just to make sure that patients across the borough have access to really excellent primary care. So that's the ambition. And there is work going on, as Mark says, in each borough, which is really tailor-made for the individual practices. So there's some things we can do generally across, but actually a lot of this is about real targeted support with practices on particular issues that are impacting on the survey results. But also, just to say, I think this is going to be really difficult to show a year-on-year improvement on these specific issues right now where we are in the world, because that survey was, I think, Mark perhaps could correct me if I'm wrong, was taken from the last January, which was before we changed anything which related to COVID and how we're working. And if the survey is done on an annual basis, I think that the relevant questions to ask of patients this January, just gone, would have been significantly different. And if you ask the same questions, you'd get really different responses for lots of reasons which weren't related to practice performance particularly. So I think it's going to be quite tricky for a few years, but that doesn't mean we won't continue to put in the support that practices need and to look at local ways of understanding, how practices are performing. And in the current environment, it's very, very challenging, and they've made a lot of changes, and it's been extraordinary what's happened, but it might not show in the survey in the same ways.
Thanks, Nicola. And Mark, back to you.
So it wasn't on that topic. It was just to go back to Liz's questions, and just to be really clear that on the 31st of March, part one will note the decisions that have already been made and discuss those decisions. It won't be to review the decision.
Thanks, Mark. That's helpful clarification. Okay, that was really helpful discussion on primary care. Let's go on to quality performance and the Quality and Performance Oversight Committee. And Pippa, you're the chair of that committee, so I'll come to you.
Thank you, Chair. So yes, we met on the 10th of February. I think the report hopefully is fairly self-explanatory. I'll just draw out a couple of points for governing body. We're about to go on and consider Jonathan's performance report. When we met, we considered the month 8 report, and obviously there has been significant major changes since that report. So we had a verbal update from Jonathan on performance across South West London, and you can see in there that there had been some excellent work that's gone on with all the trusts and with primary care and a range of our providers to help us to maintain performance. We are going to get a further update on the urgent and emergency care pathway at our next meeting next month. And also, I haven't put it in here, we are also going to get a further update on the SMI and LD health checks. So that's just to note. We had an update on the Ockenden review. So this was the review into maternity services, and we were given an update on the immediate actions that were being taken by trusts following the publication of the report. And then just finally on the second page, just to highlight, and we've heard a lot about it today, we considered the equality impact assessment for the COVID vaccination programme, and the received assurance on all the work that's going on, and we've heard more about it today. That was all I wanted to say at the moment.
Thanks, Pippa, that's helpful. And as we did with finance, why don't we go straight into the performance report, Jonathan? So if you go through that, and then we can take any questions in relation to quality or performance after that.
Thank you very much, Andrew. So in terms of performance, I'm just going to focus on those covered in the headline paper, and happy, of course, to take any questions that people may have on the more detailed report. So as Pippa has said, through the second wave, we've managed to continue many services that have been stood down through the first wave of COVID, and all credit to trusts and organisations involved in doing that. To pick out some particular strong examples, so on cancer performance, we remain the best performing in London on both patients being seen within 2 weeks of referral and receiving definitive treatment within 62 days. And our bowel and cervical screening programs are also back up and running at a full pace. We still have further to go on our breast screening program. In terms of a particularly important area, I think, for us all, given the mental health impact of COVID, is to keep our psychological therapy services running optimally. And you can see here, even often through a period over Christmas where these services often dip a little, particularly in access, both access and recovery have remained very strong. So we can be, I think, proud of where we've got to with that. Waiting times for elective care, obviously a very strong priority as ever, and overall South West London remains the best performing system for people seeking access to elective care in London, with some 77% of patients being treated with 18 weeks. In terms of 52-week waiters, as at the end of December, we had around 1,800 52-week waiters, and of course one 52-week waiter is one too many, but if you put that in the context of where some other parts of London and elsewhere in the country are, I happen to be talking to somebody who works in the Welsh health system this week, and they, for a population less than twice the size of South West London, they have 46,500 over 52-week waiters, to give you some idea of where we are in comparative terms. So a good performance in comparative terms, though obviously further work to do as we move into a recovery phase from the second wave of COVID. In terms of areas of a bit more challenge, diagnostics is an area of challenge, particularly for Kingston Trust, and particularly in the area of echocardiograms and the non-obstetric ultrasound. QPOC, the Quality Performance Oversight Committee, the committee that Pippa chairs. We had the Chief Executive of Epsom St Helier present recently, and the programme lead on diagnostics. So we've done a deep dive to give this board some reassurance in relation to that and the plans around that. And there are very specific plans that the four acute trust chief execs are very heavily involved in to support mutually each other across the system on diagnostics. 111 performance remains area of challenge, though actually South West London and our providers did better than some other parts of London through this period, so that's something positive, I think, to note. And then, as Pippa's also mentioned, and as some of us discussed yesterday, there's some more work to do around health checks for patients, particularly SMI health checks, serious mental health checks that we're looking at in the Quality and Performance Oversight Committee next month. So those are probably the summaries of where we are, and as you would expect, there will be some challenge to many of these indicators as we report on January and through February, given the pressures that have been brought to bear on the NHS over the last few months, but starting from a strong base position, I would say, Andrew. So hopefully that's a helpful synopsis, and again, very happy to take any questions.
Thanks, Jonathan. No, it's a very helpful summary. So shall I open it up to questions? So I've got questions from Bruno and Liz. I mean, what I would say, Jonathan, is I know that this report also came to the South West London Recovery Board yesterday, didn't it? And there was discussion there. And we did pick up the issue of SMI health checks. And as I understand it, the particular issue around that is the difficulty that we've had in getting patients with severe and enduring mental illness into primary care to have a complete health check, which involves, for example, having blood tests and certain physical checks. That doesn't necessarily mean that those patients haven't been cared for. It just means they haven't been able to tick all the boxes on a full health check. And I know from what Nicola said at the board yesterday that there are plans in place to really push that as we come out of wave 2 to start to get those patients in for the proper checkups that they need. So that was reassuring to hear at yesterday's meeting. So I thought I'd perhaps just mention that. Before I open it up to questions, Mark, did you want to come, or were you going to say something about that?
No, you covered it.
Okay. Shall I bring you in, Liz, then?
Thanks. I was asked to ask this by Wandsworth, and they're very appreciative of everything that St George's is doing, but they just asked me to ask about the issue of St George's and the 52 weeks plus waiting, where George's seems to have quite a bit of a problem at the moment compared to the other acute trusts.
Thanks, Liz. And actually, we've had a question from the public on 52-week waits more generally across South West London, and I think specifically in relation to Croydon. So maybe we can deal with all that now as one. So I might bring Jonathan and Matthew in. Bruno, shall I just hear your question first before we do that?
Yeah, thank you for that. It was interesting to see that the dementia diagnosis rates declined at the beginning end of the pandemic and then have stayed at approximately the same level up to date, whereas some of the others have varied according to the kind of level of the epidemic. Is there any understanding as to why this might be so?
Okay, so I'll come back to that one. Let's go to Jonathan and probably Matthew to answer the 52-week wait question. About Jonathan, perhaps you could cover the St George's issue, and I might ask Matthew to pick up where things are at in Croydon, and then I will probably come to Tonya about the dementia diagnosis question from Bruno. So, Jonathan, over to you.
Okay, so thank you very much. So I'll start by saying I think the overall waiting list for all patients is stable across South West London at the moment, and yeah, you're right to highlight that St George's has the bulk of 52-week waiters. I think a lot of that is linked to the complexity of the care pathways into a tertiary hospital, and the pressures that have been on that trust as the hub of a lot of our intensive care capacity through both waves of COVID. As I said before, obviously one too many, but we are the best performing sector in London on this. I would expect, but also to be equally frank with people, I'd expect the number to deteriorate into January and February because of the significant pressures that we've experienced. We have been using the independent sector very assertively. We have a range of providers, quite fortunate in South West London in the number of providers that we've been able to use to carry on treating patients in a timely way. Also, those patients who require the most urgent treatment or require treatment within 4 weeks that's critical to their care, we were one of the few parts of London that was able to continue to provide that care even in the very difficult weeks of early January with the pressures that we faced. So my final point is probably to say that we're doing this together, Liz, across South West London. So there is a demand and capacity unit that's been set up across the 4 acute trusts to ensure that we use any spare capacity effectively, and we coordinate that well with the independent sector. So we're very carefully monitoring waiting times across all our pathways and across our clinical networks, trying to ensure where appropriate and with agreement with patients, we're able to transfer people around the system to get more timely access to care. So that was probably what I say of summary, Andrew, and I think you might want to come to others about some of the detail.
Yeah, that's really helpful. Well, the question from the public was around that. It was 52-week waits, utilisation of the private sector, but also specific reference to 52-week waiters at Croydon. So Matthew, I wonder if you just want to quickly talk to that.
Yeah, happy to, Andrew, and I'd concur with the comments that Jonathan's made. I mean, in terms of the Croydon element of this, the report talks about 77 over 52-week waiters as of the end of December. That has gone out to 190 as of the figures yesterday. That's because, of course, during back end of December and January and much of February, we've been dealing with the second wave, and obviously, therefore, we paused some of the elective work, and it's some of those more routine patients, although, of course, not routine to the people who are waiting, who have been adversely impacted by a longer wait. Now, our focus now is to, as Jonathan describes, work out how we can and how quickly we can address those long waits. In Croydon, we are well blessed with the Croydon Elective Centre, which means that we have a protected area which we are going to be fully utilising as quickly as possible. Bear in mind, we still have 80 patients in the hospital with COVID and a very busy intensive care unit, and that intensive care unit is using some of the staff you'd use for theatre operating, because the anaesthetists are both involved in elective work and providing emergency support in intensive care. So we are planning to bring that service back as quickly as we can and start working through that backlog of over 52-week waiters. Our position in Croydon, actually, within South West London is relatively positive too. It's because we've created that hospital within a hospital. It allowed us to perhaps keep some things going for longer, which was good, and that obviously mitigated some risk, but it hasn't taken it away completely. And obviously, for the people affected, we're just very keen to get back on top of this as quickly as we can. I went through it with my teams yesterday, talking through when we can do that and how long that will take to work through, and that's something that we are finalising as part of regional and London-wide, South West London and London-wide planning that is going on at this moment. Just to make a final point that is from Croydon perspective, but more generally, Jonathan's right, we are doing this as a collective, and so things such as mutual aid, where we in Croydon can perhaps provide some capacity for other providers to be able to get some of their work done, so we can equalise the benefit of things such as the elective centre at Croydon and the South West London Elective Orthopaedic Centre, looking at a different facility to the best effect for the benefit of all people across South West London, and that's definitely how we're going to be doing this going forward. Hopefully, Andrew, that's helpful in terms of giving a sense of the scale and what we're doing about it here in Croydon.
Yeah, thanks. That's really helpful. So let me come now to you, Tony, about dementia.
So yeah, I mean, this is obviously an area of focus for the South West London Mental Health Transformation Board, and we have been reviewing the data. I think obviously in the pack it describes that the services were suspended through the first phase and have opened to a limited extent, because we have to remember this is a population cohort that has been significantly impacted by COVID and actually are still shielding. So actually people coming forward and how we encourage people to come forward to seek their diagnosis will be really important as we start to move into a more less restrictive piece for this population. So it will be working with primary care, the voluntary sector and local authorities to encourage people who could be with dementia to come forward to get the diagnosis. But I do think there's that impact between service provision having to scale down, but also this population cohort, generally the frail adults, and them being able to come forward and feel confident to come forward to seek the diagnosis whilst shielding or having had significant impact from COVID will be important going forward.
Thank you for that, Tonya.
Really helpful. Okay, I'm going to move us on from quality and performance. We don't have an update from Remuneration Committee. So that concludes our updates from the various committees of the board, and I will go straight on to item number 7 on the agenda, which is proposals around the contracts for improving access to psychological therapies in both Kingston and Richmond. And Tonya, you're going to talk us through that.
Thank you, Chair. So the governing body has been asked to approve the recommendations made in the paper in respect of the IAPT contracts we hold for services delivered in Kingston and Richmond. And we've built those recommendations based as we focused on ensuring the recommendations represent the most effective way to enable the continuation of the service provision whilst supporting transformation to be delivered. So I'll take them separately. So Kingston is provided, that service is provided by Camden Islington, and the proposal is to extend that contract for a further year. So that's hopefully that's quite an easy one. Richmond, the service there is provided by East London Foundation Trust, and they flagged in November 2020 to the commissioners that they, in the medium to long term, that they no longer wish to provide the service. They recognise that this is, as we move into integrated care, it would be more difficult for them as a remote provider. They're based in North East London to be able to continue to provide the service. And they described to us the fact that they used to hold 4 of these types of contracts across the South East. They only now have 1, which is Richmond, and they felt for moving forward it would be the right time for them to move away from providing the services in Richmond. But they were very clear, and as we were, that we wanted to ensure a safe transition for them to come out from providing the services in Richmond. So the last couple of months we've been working with colleagues, particularly in the contracting function, to make sure that we have a proposal that ensures a safe transition. So we've been discussing with the providers, local GPs, and taken advice from the contract and performance groups for the best approach to secure that safe transition. So the proposal being made to the governing body is that the CCG increase the scope and main contract with South West London St George's to include IAPT and the primary care liaison service that ELFT provide in Richmond, and that South West London and St George's will establish a subcontract for a year with East London Foundation Trust from the 1st of April to allow that year's transition. So I think we're asking the governing body to approve that contractual change. If that's approved, we will obviously work on a transition plan with our partners to ensure that safe transition, and that we include and continue to deliver the high quality standard of service that ELFT provide. And actually also I want to take the learning from ELFT into South West London St George's. So having them as a provider for another year and a subcontractor will be really beneficial for South West London. We have agreement from both providers for that approach in principle, and so we are just seeking approval from the governing body for that approach for 2021.
Thanks, Tonya, that's helpful. No, we haven't got Patrick Gibson, the GP Borough Lead for Richmond, who's had to give his apologies for the meeting, but we do have Naz, who's the GP Borough Lead for Kingston. So Naz, I guess just to come to you first, just to check your perspective on the proposals.
So I know we've discussed this at the Borough Committee, and Richmond Borough Committee members were supportive of the transition phase for the next year. As regards Kingston, I was involved with the Borough Committee discussions, but also at the Finance Committee when we did the single tender waiver to actually extend it. So on both counts, I think this is supported clinically by the Borough Committee members.
Thanks, that's really important to know. So I have a hand up from Liz.
Thanks for that. Yes, this doesn't obviously affect the decision at all, but it does relate to a point that Bruno raised earlier on when he was asking about place working. And the South West London Health Watchers are aware that the extent to which we are involved in place working at the moment is highly variable. For example, Croydon and Sutton are closely involved in place meetings, but other boroughs are not. And unfortunately, this is an example where Richmond has asked me to raise it at this point, because we note that it did go to a borough committee. Richmond support the decision and do feel that it will help address how IAPT coordinates with other services, because the service would then be delivered by St George's. So they fully support that decision. However, they are disappointed that because it was at a borough committee to which they didn't have access, that they weren't able to contribute to the discussion. And we note that in this item, it does remind us of one of the CCG objectives, which is to enable local people, patients, carers and stakeholders to have greater influence on the services we commission. So at some point fairly soon, we would like to have a broader discussion, probably not within this meeting, but with relevant people about at the moment, the patchiness of place working across the piece. Thanks.
Thanks, Liz. So I think that is a very different point, but an important one, which is about how do borough committees work. And I know we had a lot of discussions when the CCGs were merged into one about patient involvement at place. We're not going to resolve that in this meeting, but I do think we need to make sure that we're having those discussions in the right place at the right time. I mean, maybe Susan and Charlotte have a view on what the right forum might be to pick that up.
Do you want me to just comment on my understanding is that we have a community service engagement group, which obviously, going back to Bruno's point about the ICS and the transition plan, we will be having a presentation at our next meeting with Karen about how that operates. So, you know, and what the impact is and what the timescale should be and how we should engage our CVS and Healthwatch colleagues in that process and make sure that voice is paramount in decision making. But Charlotte may want to add something to that, really.
No, exactly that, Susan. I think we do need to think about the transition as regards to patient voice in the voluntary sector. We've got an introductory sort of session to think about how we do that, haven't we, next time, which Karen is going to come to. So, and it is important. We need to make sure we strengthen that. As you've got a strong voice now, we need to make sure we strengthen and build on that going forward.
I think there's also the wider issue, isn't there, about how we, regardless of the role of Healthwatch to some extent, it's about how we make sure we're properly involving patients in developing proposals and how, if we are changing services, we're genuinely engaging with in co-creation with the patients who are going to end up using the services. So I think that's a broader principle that we all adhere to. The specific role of Healthwatch and the voluntary sector in the decision-making processes, I absolutely think we need to make sure we sort that out as we think about the transition to the ICS, so we can make sure we build that in effectively as well. Pippa, shall I come to you?
Thank you. So really, it was just a comment to Tonya. I looked at this paper through the Finance Committee, so it's gone through that route. But I think you've given us the assurance today from a quality perspective around taking the learning from ELF to South West London and St George's and making sure we're absolutely embedding best practice. So I just support it. I thought it's a really good process and a good example of providers working collaboratively. It's good. Thank you.
Thanks, Pippa. And then Bruno?
Yeah, I'm aware of the kind of history of this this contract because I just started working in Richmond just slightly before it moved to East London, the provision. And although there were improvements in performance, radical improvements in performance, in fact, it's interesting to note that in fact public and patient involvement suffered slightly from having an out of area provider. So I think that the proposal is really very sensible and necessary, and I think that there is potential there if that transition year is going to be used to try and make sure that the public and patient involvement mechanisms around that area improved. I think that it has a really good potential.
Thanks, Bruno. That's really useful feedback. So I think there aren't any more questions or comments. So I'm going to put the question to the board. We're being asked to make a decision on, first of all, the Richmond contract, and then secondly, the Kingston contract. So the first decision is to agree the commissioning approach of varying the South West London St George's main contract to include Richmond, IAPT and PCL, with the provision of ELFT being subcontracted by South West London St George's for 21-22 to allow for a year-long transition of service. So are we in agreement with that? That's yes, so that's approved. And then the second is to agree the single tender waiver for a 1-year contract extension with Kingston ICOPE, Primary Care Mental Health and Substance Misuse Services with CNI. And so I'm looking for approval for that as well. Okay, so that also is approved. Thank you very much. Thanks, Tonya. And it's back to you again for item 8. This is an update on Kingston and Richmond community provider collaboration, and this is for information to the board.
Yes, thank you, Chair. As you said, this is an update. As we thought, as this was the last public meeting before we award the contract in April, we thought it was an opportunity to update the members on progress. So just to remind members, the proposal is to award a single contract for the 2 community providers from the 1st of April with HRCH, which is Hounslow and Richmond Community Health Trust, as the lead provider. So by awarding this contract, we'll be able to deliver a new community service model, which provides best value, demonstrates better outcomes, and proves to be operationally and strategically resilient. We had no challenges through the formal process. The OJ, we put our notice there, we had no challenges. And we've completed a due diligence piece with both providers around a number of areas. And from that due diligence, we have agreed several actions with both providers, particularly around the sharing and strengthening of clinical leadership, with the proposal that they have a joint appointment for a medical director and a director of nursing, and they will be joint posts. Will be created from the current post holders, HRCH, becoming joint posts for your healthcare. So this has been agreed in principle by the 2 providers, but because of the timing of boards, they won't be able to ratify that formally until the week beginning the 15th of March, when they are due to meet. So as the boards haven't signed this proposal off formally, there is a risk, however small, and it is small, that the proposal for the joint post will not be signed off. And I just wanted to flag to the governing body, if that is, if in a very unlikely event of this happening, the CCG will need to reconsider the award of a joint contract, because we felt it was a significant piece of work that needs to be done by both providers to strengthen that clinical leadership. And if that's the case, we flagged to the providers that we would have to consider the option of procuring if they weren't able to reach to an agreement on that proposal. However, I've met with both chief executives. I'm absolutely assured that will happen, but I did think it's important that we raise that as a potential risk, however small, to the governing body today, just because of the timing of the board's meeting.
Thanks, Tonya, that's helpful. Naz, can I come to you just to get your perspective, because obviously this is a Kingston and Richmond issue.
This has been discussed again at the Borough Committee and also at the Council of Members and the membership meetings, and has been supported. The awarding of the single contract has been in discussion for a number of months and has gone through the correct processes at a local level.
Thanks, Naz. So are there any questions for Tonya on this from the board? No? Okay. Thanks, Tonya. So that's noted. Well done. It sounds like you're taking that forward in the right way. Okay, let's go on to item 9 on the agenda, which is the board assurance framework, and this is for discussion. So, Ben, over to you.
Thanks, Andrew. This is now the second time that we brought the BAF, the Board Assurance framework, to the governing body. As you'll be aware, there's a more detailed corporate risk register that sits behind this, and each of our committees considers the risk relevant to their committees on a regular basis. The BAF has continued to evolve over the past few months since you've last seen it, as you would expect, and as you will note, we've closed a couple of risks over those months as the pandemic itself has evolved over that time. The BAF provides you with the top key risks facing the CCG and also those that we think you should be aware of, either because they're of a particular significance, excuse me, or because their scores are increasing. We currently have 4 risks on the BAF that are scored over 15 and a further 9 that are below 15, but we wanted to draw to your attention. There's one new risk since the last time you saw the BAF, which is risk 101, which is around the rollout of a vaccine, and as you would expect to see it there as we've progressed over the past few months. And there's one revised risk, which is BAF 3, which is regarding the CCG's response to the pandemic and has just been reworded since the last time you saw it. We've closed 3 risks over the last period, which is BAF 1, which is around the lack of supplies, 030, which was around the lack of rapid testing, and 082, which was a potential failure to meet the flu targets. We've closed all of these because they've met their target scores. So if I can suggest that if you've got any detailed comments around the drafting of the risks themselves, then I'm really happy to take them outside of meetings. Please either drop me an email or give me a call and we can discuss in more detail. So I think the real things for the board to consider are whether you're happy that we have captured the right risks on the BAF, whether there's anything that you think we have missed, and I think whether you think we've got the right balance of risks reflected on the BAF, and whether that scoring is correct.
Thank you, Ben. So, I mean, I know obviously these risks are considered in more detail in the individual committees, but coming to your question then in terms of whether the risk register is correct and does it capture all the key risks and have we scored them right, I guess that's the question for the board. So I'll open that up. Does anyone have any particular concerns? I guess particularly with you thinking with your respective committee chair hats on. No. So I'm assuming then that's broadly people feel that this is absolutely right. But let me come to Paul, you first, and then to Pippa.
Yeah, no, I just wanted to validate that, Chair. I know I've been through this through Audit Committee with Ben a couple of times, and I'm comfortable that the framework and the risks identified are appropriate, so I've got no major issues with what's been produced.
Thanks, Paul. That's very reassuring to hear. Pippa, let me come to you.
Thank you, and thanks, Ben. So I think this is really very helpful, and the areas that the Quality Performance and Oversight Committee have oversight on, well, it works 2 ways really. I use this to make sure that our forward plan is covering off some of these areas, and I'm also confident that the areas that we're identifying are being reflected in here. So I think currently, as it stands at the moment, I haven't got any further comments to make.
Great, thank you. Well, That's good to hear as well. So I will take it that we've noted that and we've considered the risk register and we're happy with it at this point. So thank you very much, Ben. Really helpful. But back to you for the IG annual report, which again is for us to note.
So I wasn't really planning to say much on this, Andrew. It's for information and awareness for the governing body, as the Information Governance Steering Group is one of our committees that oversees our information governance response across the CCG. I think there are a couple of key points noted in there, but nothing I would particularly need to or want to draw to the governing body's attention. So I think if people have had the chance to review, then I'm really happy to take any questions or indeed talk to anybody about it outside of meeting if they want to.
Thanks, Ben. So I'll give people the opportunity to do that, to ask any questions or raise anything now. Obviously you've got the option to pick that up with Ben going forwards, but I'm assuming it looks like people are content with that, Ben, so thank you. Really helpful to note that. So that takes us on to the final part of the agenda, section 11, which is questions from the public. As I said, we hadn't had any sent in advance. We'd had one during the meeting on 52-week waiters, which we've answered as part of that section of the agenda. And then there is one more question that's coming, which is how many patients are on waiting lists across South West London? Jonathan, I don't know whether you have that answered to hand, and obviously it's a broad question because as we know, the people on the waiting list are in various different states of need. I mean, what I would say on this is I'm quite confident that we know who we have on our waiting list, and we've also been through a process clinically as a South West London system to validate those waiting lists and prioritise patients on the waiting list, so we can be reasonably confident that those people who need urgent treatment are getting it, those people who need treatment within 4 weeks are getting it, and that those who are waiting longer fit into what we call the priority 3 or 4 categories, which means that we don't believe they're going to come to significant harm from a longer wait. That doesn't mean that that is an acceptable position going forward, but it does mean that we're doing what we can do to make sure that we manage the risk of having longer waiting lists, some of which have come about because of the COVID pandemic. But Jonathan, do you want to pick up that specific question?
Yes, very happy to. And just to reiterate, I entirely agree with you, Andrew. We've led a lot of the work with across London, haven't we, around clinical prioritisation and ensuring the right patients are getting treated in a timely way. So just to reinforce that I think we're assured that is the case. The specific answer, I think, to the question, which is probably, there are, as you say, other waiting lists, such as the diagnostics waiting list, but the specific answer, I think, to the question that's posed is probably relating to the inpatient and day case overall waiting list. And I'm going to, there's a difference also between the CCG cut of it and the trust cut of it. But if I give the CCG view, it's actually in the deck. It's 112,000 patients. That's the overall number of patients who are waiting for a inpatient or day case procedure across South West London. As I say, you can see the detail of that under the referral to treatment time section of the performance report. See that by provider. There's also more data on diagnostics as well in there, showing some 28,000 people are currently waiting for diagnostic procedures across South West London. So hopefully that answers that specific point.
Yeah, and it might just be helpful, Jonathan, to put that in context. So we've got 112,000 people on the waiting list. Do you have an idea what it would be in normal times? So if we weren't in the middle of a pandemic, how does that compare with 2 years ago, for example? Did you have? You might not have that to hand, but you could give us a sense of it.
So I don't hold the precise number from 2 years ago in my head. I hope I can be forgiven for that, Andrew. But what the deck also shows is that it's been stable over the last 3 or 4 months. And I suppose, so for example, the figures, it's fluctuated between 111,000 and 112,000 over the last 3 or 4 months. I don't think the overall waiting list position has grown significantly over the last 2 years. People will remember 2 years ago we were at the end of the St George's data reporting issue, so that will have coloured the numbers, but I don't think the overall position has changed significantly. What I do think we need to be mindful of is that, of course, a number of people will not have come forward for treatment when they should have done, for a whole variety of reasons through this wave of the pandemic, and that is something we're looking at very carefully. We're trying to understand what their shortfall is in activity, say, coming forward in cancer referrals, and it's very pleasing to see actually in December, that was the first month they had more referrals for cancer than we had a year previously since the start of the pandemic. So it's good to see that that we're seeing those cohorts of patients who are at risk coming back. But I think it would be true to say we can expect the waiting list to grow as all those people who need a range of procedures, from obviously people requiring serious intervention to much more minor conditions, come through through their GP and outpatient diagnostic and then onto the waiting list. We can expect that number to grow going forward. But as I say, hopefully I've answered the very specific question about what is the overall proportion of the population in South West London on the waiting list at this point in time.
Yeah, thank you. That's really helpful. Okay, so I don't think I've had any more questions. Nothing else has come through, has it, Ben?
Nothing more.
Okay, so that concludes that section of the agenda, and I haven't been notified of any other business, so I'm going to bring us to a close. I just wanted to say thank you to everyone for your time. Thank you to people who've kind of tuned in to watch, and thank you particularly to the exec team preparing a lot of the reports and talking them through. That's been incredibly helpful. So I will draw us to a close.